On to chapter 22, where we're going to talk about chronic heart failure. So chronic heart failure is the inability of the heart to pump enough blood to supply the tissues and organs of the body with oxygen and other nutrients. Cardiac muscle undergoes hypertrophy, which means it gets bigger as it has to try harder to pump against the force that it's up against, where the walls of the heart chambers increase in size and undergo structural remodeling in an attempt to generate more forceful contractions. So why does the heart need to generate more forceful contractions? We talked about the narrowing of the arteries in chapter 21, and what happens when those arteries narrow is it puts more pressure on the heart. There's less space to push the same amount of blood through, so the increase in the amount of force that is acting against the heart goes up. The heart therefore has to try harder and push it against that force. So in order to try harder, just like you would to lift weights, your muscles would have to get bigger. So on slide 5 talks about the renin-angiotensin aldosterone system, or the RAS, R-A-A-S, renin-angiotensin aldosterone system. This is a system that controls our blood pressure as well as our fluid balance. It can be kind of complicated to understand, but in order to understand how some of the medications work, you at least have to have a basic knowledge of what goes on here. So the kidneys respond to chronic heart failure by releasing a substance called renin. Renin stimulates the enzymatic conversion of a precursor protein from the liver, which is angiotensinogen, to angiotensin 1. An enzyme produced by the lungs, angiotensin converting enzyme, converts angiotensin 1 to angiotensin 2. Angiotensin 2 is a potent vasoconstrictor and also stimulates the release of aldosterone from the adrenal cortex, an antidiuretic hormone, which holds on to water, from the hypothalamus and pituitary gland. This sequence of actions is referred to as the renin-angiotensin aldosterone mechanism, or RAS, which is system. Aldosterone is a hormone that causes retention of sodium by the kidneys, and ADH acts on the hypothalamus to stimulate thirst and the kidney tubules to retain water. These actions attempt to increase blood volume and therefore blood pressure. Anytime you increase blood volume, you're going to increase blood pressure. In most normal people, this system functions perfectly and normally. When you have chronic heart failure, that's when things start to get a little funky. So as you can see at the top of that picture, decreased cardiac output, decreased blood pressure, and decreased renal blood flow, which leads to increased sympathetic discharge. So therefore, if we increase sympathetic nervous system actions, we increase force, rate, and vasoconstriction to compensate and increase cardiac output. And now on the other side, when we decrease renal blood flow, we increase renin release, and therefore we increase angiotensin 2, leads to vasoconstriction, increased antidiuretic hormone, and increased ADH. Okay, so hopefully that gives you a little better knowledge of the renin-angiotensin aldosterone system. So moving on to the next picture. I hate pictures, to be honest with you guys. They're very hard to explain because they are so tiny on these slides. So the best place that you can follow along is not on the slides, but probably in your book. These pictures should also be in your book, okay? At the top of this picture, we have our liver. So let's go into this one. Just talking about how the liver, when there's a drop in blood pressure, leads to angiotensinogen being released. Renin from the kidney converts angiotensinogen to angiotensin 1. ACE, or angiotensin converting enzyme, from the lungs converts 1 to 2. And remember, 2 is our potent vasodilator, which leads to an increase in blood pressure. Nasty little cycle for someone whose heart is already pumping against a lot of force. When we increase blood pressure, we're causing what's called a positive feedback. What ends up happening is the heart just has to keep trying harder and harder and harder because the blood pressure keeps going up and up and up in order to compensate for the decreased cardiac output, okay? So again, this system in normal people works fabulous. In people with chronic heart failure and other problems, it basically creates just a huge mess. So, treatment for chronic heart failure has 4 classes: cardiac glycosides, vasodilators, diuretics, and beta blockers. The treatment of CHF has evolved over the years, started off with cardiac glycosides, also referred to as digitalis, and those stimulate myocardial contractions. And it's moved from digitalis to drugs such as vasodilators, diuretics, and beta blockers. So vasodilators that primarily dilate veins decrease venous return. So we open up our veins, there's less blood going back to the heart, it's starting to pool down in the smaller blood vessels. So those decrease preload. Preload is the amount of blood returning to the heart to be pumped out again. Decreasing preload or afterload, actually let's talk about the arteries real quick. Vasodilators that dilate arteries, which are the ones that deliver oxygenated blood, reduce blood pressure and peripheral resistance and decrease afterload. Pre meaning how much is coming back to the heart, after meaning how much the heart has to pump against. Decreasing preload or afterload or both decreases the workload of the heart, which means the volume of the blood that the heart must pump, and allows the heart to contract more efficiently. So that's vasodilators. Diuretics have been very useful in CHF. We talked about in chapter 21 how there's accumulation of fluid in CHF, which leads to impaired blood exchange and swelling of the extremities, as well as congestion. It can also be a problem in the patients with lung function. So beta blockers, diuretics get rid of that fluid, and last but not least, beta blockers reduce the heart rate and sympathetic activation, which is usually excessive in CHF. So let's start with diuretics. This is the simple, most main therapeutic effect that people will usually start off with, getting rid of that fluid. So we're decreasing the blood volume. Okay, we're not getting rid of blood, we are simply decreasing the amount of fluid, plasma volume, to bring the blood pressure down. The main therapeutic effect produced by diuretics is the elimination of excess sodium in water by the kidneys. Sodium and water retention are the main cause of edema and congestion in CHF. There are 3 types of diuretics: the thiazides, organic acids, or loop diuretics, and aldosterone antagonists. So on slide 9 we have examples of all of those. Thiazides sound exactly like that at the end of their name: chlorothiazide, hydrochlorothiazide. Thiazide-like diuretics include chlorthalidone, indapamide, and metolazone. And organic acid or loop diuretics include bumetanide, furosemide, and ethacrynic acid. Again, don't worry about the duration of action too much, just start familiarizing yourself with the name. Last but not least, potassium-sparing diuretics or aldosterone antagonists, amiloride and eplerenone, as well as spironolactone. And you'll learn about potassium-sparing versus potassium-wasting in a different part of the book when we get to talk about vasculature. Okay, so keep in mind, potassium sparing means it allows potassium to stay in the body. Potassium wasting, or the top couple of categories there, means that a side effect of those diuretics is to get rid of excess potassium as well. Potassium follows sodium and water out of the body. Changes in our potassium can be dangerous. They can lead to cardiac arrhythmias, which you'll also learn about in the future. So just keep that in mind. Vasodilator therapy. The main effect of vasodilator drugs is to relax or dilate blood vessels. Vasodilation lowers peripheral resistance and blood pressure. These changes decrease cardiac work and oxygen consumption, and the heart is able to pump more efficiently with less effort. So it's able to do more with less. Vasodilator therapy of CHF has been shown to be very beneficial, especially with drug classes known as angiotensin converting enzyme inhibitors, or ACE inhibitors, and angiotensin receptor blockers, or ARBs. ACEs and ARBs are the cornerstone of a lot of treatments. Blood pressure, diabetes, to keep the kidneys safe, so you'll see them everywhere. Other vasodilators, hydralazine is a potent vasodilator that produces arterial vasodilation, again, a reduction in afterload, decreased blood pressure, so all that happens with hydralazine. Adverse effects are mostly due to excessive decreases in blood pressure and include nausea, postural hypotension, which is where a patient stands up too quick and their blood pressure drops, and reflex tachycardia, which is a response to the medication where the heart rate shoots up. Nitrate drugs, venodilation, they cause venodilation, which again decreases preload. The amount of blood returning to the heart is decreased, allows the heart to pump more efficiently, and increase cardiac output. Adverse effects include headache, dizziness, flushing, and postural hypotension. If we had to cover, we already talked a little bit about our ACEs and ARBs. So ACE inhibitors, if we can prevent the conversion of angiotensin 1 to angiotensin 2, we decrease that sort of loop there where the blood pressure is increased. If we can block the angiotensin receptor, same exact effect. Slightly different mechanisms of action, same exact result. So both drug classes produce a balanced vasodilation, and it inhibits the actions of angiotensin 2, inhibits the release of aldosterone, as well as antidiuretic hormone. Adverse effects include headache, dizziness, hypotension, hyperkalemia or increased potassium, and GI disturbances. So sometimes with hyperkalemia, that can be a problem, and we do see patients on both diuretics and this type of vasodilator in order to sort of balance out potassium loss. Hyperkalemia from ACE inhibitors and ARBs, and hypokalemia from diuretics. ACEs can also cause a dry cough and allergic reactions that can cause swelling of the lips. These are side effects that can be bothersome enough to where the patient has to be taken off the medication. So slide 13 has vasodilators that are used to treat chronic heart failure. Again, get familiar with the names, read the comments, and try not to stress out about memorizing too much about them, but it is really important to know what class they fall in and some general facts about that class. So the use of beta blockers in congestive heart failure. They block beta-1 receptors on the heart, so they decrease heart rate as well as force of contraction. If you block beta-1 receptors in the kidneys, you reduce the release of renin and reduce the activation of that RAS system. Metoprolol and carvedilol are the preferred beta blockers for CHF. Last but not least, glycosides are older class of drugs. These are obtained from plants such as Digitalis purpurea and Digitalis lanata. The actual name of the plant that some people might be familiar with is foxglove. It's a very pretty plant, however, it gives us this drug. The unique and main pharmacological effect of digoxin is to increase the force of myocardial contractions, also referred to as a positive inotropic effect, without causing an increase in oxygen consumption. So kidney function increases due to the increased cardiac output and renal blood flow, and therefore we cut down on the activation of that system that increases our blood pressure. A second action of digoxin is to stimulate the vagus nerve, which slows the activity of the SA and AV nodes and slows the heart rate, so a negative chronotropic effect. So digoxin follows a sequence known as digitalization and maintenance, meaning a load and then a maintenance dose. So we have a high dose to start with and then a maintenance dose that keeps the patient stable. Hypokalemia is a problem that is a side effect of digoxin, and it sensitizes the heart to digoxin, which can be a bad thing. So if we have too low of a potassium, digoxin can quickly become toxic. So it can lead to ventricular fibrillation and death. Many patients with CHF are also treated with diuretics, so we do want to keep an eye on their potassium intake and levels. So fruit juices, bananas, vegetables are a good source of dietary potassium, and patients are monitored to make sure that their potassium is within the normal range. Major adverse effects of digoxin: nausea, vomiting, headache, visual disturbances, and cardiac arrhythmias, and it also comes along with quite a bit of interactions, so we do have to be careful with this medication. So let's talk about preferred therapy for mild CHF. We want to decrease their sodium intake and put them on a diuretic. As CHF becomes more severe, ACEs and ARBs, our vasodilators, are added. If tachycardia is present or rapid heart rate, low-dose beta blockers. Digoxin therapy is considered when diuretic and vasodilator therapy do not control symptoms, and this is strictly because of the amount of interactions that come along with digoxin. So even though it's an effective drug, it's our last line because of problems with the medication. Monitoring required, excessive things that have to happen in order for a patient to be stable on that medication. Move on to chapter 23 next. And if you guys have any questions on this one, I know it's probably a little difficult, feel free to email me.